Hi, Penelope McMillan, spokesperson for ME/CFS Australia and advocacy lead for ME/CFS South Australia. I'm going to tell you a story about patient impact in research, and throughout that story there'll be themes that cover the topic scope, networking, communication channels, roles, and tasks. The starting point for this project was a report by Ricky Buchanan called Just Invisible that Ricky published in 2018. The subtitle is Medical Access Issues for Homebound and Bedridden Persons. And Ricky encapsulated the problem as, if you are homebound or bedridden and you live in the community, then the healthcare system treats you as if you do not exist. The first connection was Ricky and myself. We both have ME. We're engaged in the same private Facebook groups, and we communicated through Messenger. The second connection was Alejandra and myself. We were both active in health consumer advocacy. We're involved with the Health Consumers Alliance of South Australia. We're involved with SAMRI, the South Australian Health and Medical Research Institute, and with Health Translation SA. The three of us were brought together when the Consumers Health Forum held a conference with a competition to present a big idea in health transformation. So we chose to present on transformation of healthcare delivery for homebound patients. We then picked up some critical allies. Alejandra by that stage was working as a researcher at Flinders University and was given permission to incorporate frail, homebound and bedridden people into her work. And then the Caring Futures Institute at Flinders University gave us some funding to kickstart our research. Defining the scope. This project started with ME, but we looked at what will capture the imagination of funders, politicians and the public, and what fits with the existing research literature. Alejandra did a lot of work on the scope and came up with the concept of frail, homebound and bedridden people, FHBP. The first thing was to spread the word. It's not by accident that Ricky's report was labelled Just Invisible. So we created videos, we presented at conferences, we had a conference poster. You can see it here. The title is Exclusion from Primary Healthcare, a Barrier to the National Disability Strategy Implementation. In other words, it's that recurring theme that if you don't have access to healthcare, then you don't have access to disability supports, you don't have access to income support. It just cuts you off from all other services. We also did a video presentation on the Australian Health Journal, which is a video-based health journal. Then we got into the research. The theme of this initial survey was making the invisible visible. And it was critical for consumers to be involved in co-design from the very start. What is the research question and what's the research design? What survey questions will be included and how will they be worded? We came up with together with the concept for these photographs, where people who chose to do so would include in their survey response a photograph of their hand touching something that is important to them, possibly something that they can no longer do or no longer participate in. And then we help with recruitment. We get involved with the analysis. It's very easy for people who don't have lived experience to misinterpret the data they receive, and also to be involved in the publications. With academic publishing, I was involved in co-authorship, in consulting, and in editing. The sort of publications we produced were academic papers, book chapters, and a multimedia conference presentation, which is quite innovative. And if you want to attract people's attention at a large conference, innovation helps. With the scope, if you're looking at participating in research, consider a wider scope than ME. You bring in more allies, it can increase the power of the research. And consider alliances. Who else might lend power to the work you're doing, provide resources, expertise? On the other hand, we all know from, I just have to say the word pace trial, and a lot of you will shudder and recognise that often it's important to ensure there is a narrow scope, if that is relevant. Maybe the scope is just people who meet a particular diagnostic criteria for ME. It may be a subgroup of people with ME. Your scope is critical, and consumers should be involved in that alongside the researchers. Networking. It's important to me to network inside the MECFS community, locally, nationally, internationally, and beyond the MECFS community, to be engaged in networking with the disability sector, the health sector, the welfare sector, and to engage with consumer researchers in other fields. Also to be involved with research institutions, with advocacy organisations, and with research funders. Communication channels, the more diverse your communication channels, the more people you're going to be able to interact with. Teams and Zoom, very popular, but they don't work for everyone. Email, Messenger, private Facebook groups, public social media. The sort of roles that you can take include being just a general consumer. I'm a person who uses the health system, and that's enough to have a different perspective than a researcher might have. Often a lived experience consumer is what's required. Someone who has personal experience of the topic of the research. It can be very beneficial to operate as a consumer representative. If you're going to claim to be a representative, then you need to ensure that you are networked with a wide range of people with a diversity of relevant lived experience. So, for example, if I'm going to a meeting, within the bounds of confidentiality, I will put to perhaps a private Facebook group with thousands of members, here's the meeting I'm going to. What do you want me to tell them? What questions do you want me to ask? And then I can claim genuinely to be a consumer representative. The next option for those who are very familiar with the literature is to be an expert consumer, to have not just lived experience, but a really good knowledge of the literature. Often we are better informed about the literature than the clinicians, than the researchers. And that can be an extremely valuable role in a research team. The sort of tasks that we can assist with include consulting with the research team, consulting with the ME community or the wider community, getting involved in research design, particularly including the research question, grant applications, recruitment into the study, analysis. It's all very well to have quantitative and qualitative data, numbers and stories. But if you don't have the lived experience, it's easy to misinterpret that data. Writing, editing, and promotion of publications. It doesn't matter how many academic papers you put out. If nobody reads them, they're not going to have any impact. In the long term, Alejandra and I are co-leading a research and innovation project for health and social inclusion for frail, homebound, and bedridden people. Thank you for being here, and we're now available for questions.
Okay, well, I'll open the floor, Alejandra and Penelope, if you wanted to add anything, but also if there's any questions anyone's got.
I apologize for the low volume of my video. Hopefully the YouTube version gets better quality. And well, I have to thank Penelope for that fantastic presentation. I didn't get to see it before she presented it today, and I think it's incredible. Thank you very much, Penelope.
Well, Alejandra and I are a mutual admiration society. We've known each other for a long time now and consider ourselves friends. And in fact, that's how this whole project started, because at an event at Health Translation SA, we chose to sit together because we're friends. And I've been pushing Ricky's report, Just Invisible, at everyone I could imagine: politicians, journalists, researchers, senior public servants. Nobody have picked it up. And I mentioned it to Alejandra, and here we are today. So at the beginning, really, still, even though at one stage, Alejandra counted how many public expressions of our work there had been in terms of videos and conference presentations and papers and book chapters. There's a slide of it. You can't read the slide because there's so much on it. It just shows you the immensity of the work that's already been done. And yet it's still just the beginning of creating change, which is the purpose.
It was good. I liked how they both complement each other. I just as a reflection, and Alejandra, probably a question for you. Like, as a researcher, does having that input from the clients, like that, I suppose that was the main thrust, but does that really aid the quality of the research or the outcomes that you get?
Yes, and I am the group is increasing now, but I am one of the few researchers that believe that without end user, consumers, and other people connected to any problem, research problem, research cannot solve and bring solutions to whatever it is you're researching. So consumers, like Penelope explained, helps to interpret data in different ways. One thing, when you have a clinic, and we had previously clinicians presenting, you have a clinical training that makes you wear a specific hat, a way of thinking. And that's your training. And sometimes you are actually conditioned not to think outside that box, because that will improve the quality of your study. So the problem is that when you do that, you kind of narrow so much everything. And remember that today problems like ME, obesity, discrimination, racism, all these things are very complex problems that one single view cannot bring a response or something that will influence the whole system. So having consumers giving this angle that we cannot access, having other professionals giving their perspective and analysis of the same information might help us to create things that influence the whole system and not just one specific aspect of it, because that's a problem. We have compartmentalized our studies to be very accurate, but they don't. In that way, we cannot then translate them to reality.
I have one comment. Somebody mentioned, and I think it was Julie, somebody commented about long COVID as allies. And in Australia, we're fortunate that the ME/CFS community and the long COVID community have a high level of not just mutual respect, but interaction. So, you know, I have people who are prominent in the long COVID community in Australia who I have their phone number, I can talk to them on Messenger, I have their email address, and I've been in meetings with them. So we are, without question, doing everything possible to be complementary, not just in research, of course, but also in our political approaches.
It is complicated though, because I suppose long COVID and ME/CFS or ME/CFS, and those that, as we sort of said, there's a challenge by if you pull them, then the same treatments rolled out for all of them, but that might not be the case. But it's yeah.
The fallacy is that long COVID is similar to ME/CFS, and that is it's an absolute fallacy. Around half the people with long COVID have ME/CFS. Yeah. It's very common for ME to be triggered by infection. Yeah. And we knew the minute the pandemic started, the ME community is saying, you're going to have an avalanche of people with ME. And the rest of the world's going, oh, stop being silly, you're catastrophizing. Well, the fact is that we do. So around 50% of people with long COVID, they have ME, and they belong inside ME studies. And in fact, they're really instructive because you can look at people in the early stages of ME and compare them to people who've had it for longer. Because plenty of immunological studies that indicate that in the first 2 to 3 years, people's immune systems operate one way, and then they flip and operate in the opposite way. So it's a really wonderful opportunity. But 50% of people with long COVID do not have ME. ME studies and ME guidelines are completely irrelevant to them. And we're doing them just as big a disservice by saying, oh, their condition is like ME. Well, if you've got lung damage and you need rehabilitation from a respiratory specialist, you don't need ME guidelines, right? So everybody loses when people say that long COVID is similar to ME, because it's a fallacy.
And that's what I recently learned, was that it's similar, but it's not the same. And
oh, no, it's not even similar. Half of the people have ME, half of the people have organ damage, they have strokes, they have cardiovascular events. They're not even similar, right? So that's, you won't move me on that, because the literature is really clear, and we're harming everybody when we conflate the people with long COVID who have ME and the people with long COVID who don't. Everybody loses.
Yeah, but based on our study, so respecting that and having that clear, we have to unite forces. So people with ME, people that consider themselves living with ME/CFS, people with any sort of autoimmune conditions. Look, Penelope and I connected so much because I had a mismanaged Hashimoto's disease. And when I couldn't manage my Hashimoto's disease, which is an autoimmune condition, I couldn't stand from my bed. Yeah. I couldn't get a shower. I couldn't, because I didn't have the proper medication. So I experienced myself what it's like to be homebound and ignore and being seen as a crazy person that is lazy, that doesn't want to wake up and work. And so based on that connection, we created all this program that now is being referenced in submissions to the Royal Commissions. It was disseminated by the World Health Organization when the COVID pandemic and the ethical issues around it, the fact that the homebound people could access for the first time in Australian telehealth without being in person. These kind of ideas have been disseminated a lot, and hopefully with our systematic review, the one that I just generally mentioned in my presentation, this is going to trigger more impact, because globally, like I said, we reviewed the whole literature around using telehealth for homebound people and not in-person care, and we found 8 studies around only from USA and Canada. So studies meaning there are clinical trials, quantifiable and replicable, because there are studies touching on certain aspects, qualitative studies, and our intention was, so let's unite us. Let's say, look, all these people have similar needs in terms of care access, and that's why it's important. We also should consider alliance with rare diseases organizations. There is one in Australia. I know that they have a lot of meetings, etc. So we should. Of course, endometriosis. Same condition, but same experience of not being believed, not having access to care, and not being supported. Well, and now endometriosis have more support, but I don't quote me on that.
So I want to say that when we, MECFS Australia, successfully had changes to the DSP, Disability Support Pension impairment tables enacted into law, what gave us an in was that, well, first of all, we put in a big submission, but secondly, we're invited to a chronic illness witness session for the Senate inquiry, and we were reporting alongside cystic fibrosis and multiple sclerosis. And because those three groups were able to draw common concerns about the disability support pension, then MECFS Australia was asked to critique every single table and to propose recommendations for change. And because we took, for example, a broad view, energy limiting chronic illness, and wherever we have illnesses where people's functional capacity fluctuates, everywhere we could draw groups together, we did that. However, the tables also specifically mention now post-exertional malaise, MECFS, fibromyalgia. They are written into the tables where in the past, people with a whole stack of conditions, and particularly fluctuating conditions and energy-limiting conditions, had real trouble meeting the impairment tables criteria to get themselves a disability support pension. So it was drawing on commonalities that, I'll use the word power again, that's where the power came from. And that allowed us to make a change in the law that benefits our people specifically, but helps a lot of other people as well. Someone I know with MS, quite advanced MS, have been knocked back and knocked back and knocked back. The new impairment tables came into the law and they were on the DSP in 2 months. And we did that, but we wouldn't have got what we wanted for people with ME if we hadn't included everyone else.
Mm-hmm.
Yeah, and with the business model that we live in, unfortunately for research and any policy making, we need to justify how big is the problem. Tell me about the quantity of people that impacted by it. And that's where this rationale of uniting forces come from.
Yeah.
But as I said in my presentation, if the study is about ME, then every single person in that study needs to have ME, and it can't be self-reported, because there's plenty of literature showing that self-reported ME tends to include a pretty high proportion of people who don't have ME, but whose doctor has said, gee, you seem to be tired all the time, you probably have ME. So if you want to study ME, you need to make sure that's what you're studying.
That's really good. That's awesome. It's a great
we could talk forever, the two of us.
Is there any other questions? I mean, we could, because we might move on to the last session with, and then we can come back for a further open conversation at the end as well. But I think, yeah, both presentations are really good, and it's just all feeding in together and really, I suppose, reinforcing the message today. So in terms of that understanding and support in a way that's meaningful, so and thoughtful. So yeah, no, that's great, guys.